they're not really motivated. I use this example. I would say that we have neuroimaging studies and evidence that suggests that there are bilateral changes happening in the brain as a result of therapy. Your brain can actually change as a result of therapy. That's a powerful message to give to your patients who are not motivated about therapy. So I would say that it would just boost the plasticity so much more that they would be missing out on it if they choose to decline therapy. And again, it is their call at the end of the day, but still you have to do your job in trying to encourage the patient to receive interventions and to do what is best for them. Researchers also, however, there isn't a lot of conclusive evidence on this, but researchers do agree that therapy-induced plasticity is present even in chronic conditions, which is, all the more reason to encourage, especially patients who have aphasia, who live with aphasia for years after their diagnosis. So even in chronic stages, therapy-induced plasticity does occur. And that, again, is a finding that is in our favor as speech pathologists. So when a person does have a brain injury like stroke, there can be many routes for the type of intervention that is best for the client. It could be pharmacologic treatments, it could be behavioral interventions. There are also brain stimulation methods that are still in the research phase. It's not clinically applicable yet, but hopefully in the future. But we as healthcare professionals, as speech language pathologists, we would be interested in this, in the behavioral intervention piece. So now that we know that therapy-induced plasticity, or therapy does induce or enhance plasticity, we know that. But the question is, how can we enhance plasticity using therapy? What do we need to do in our interventions to enhance plasticity or to trigger plasticity? Well, two things. One is to really design interventions that are challenging and that are complex, so that you are actually stimulating the brain's, different regions of the brain to fire, to form new neural networks, to form new pathways. And for that to happen, the tasks that you do really need to be meaningful and challenging and complex. And the other piece is repetition, or engaging the client or the brain's network repeatedly in a particular activity. So thinking about London's taxi drivers, for example, they did not have that ability to navigate through the London city streets. They did not acquire that in a month or two. I'm sure it took years of doing the same activity over and over again, driving through those streets over and over again for years has led to that neural network formation, which makes them become really efficient at that task. So the same thing applies here. We want our patients' brain networks to really function effectively, efficiently. And for that to happen, we need to have the tasks that we provide need to be repeated over and over again, so that those neural structures involved need to fire again and again, sequentially, coordinate with one another in the brain. And only then does the network really form. Only then does the pathway become, the pathway really is formed and is functioning. And then it would lead to learning. The person is able to produce whatever the target really was because the pathway has been established. So repetitive engagement of brain networks is key. So that leads to repetition being the core of therapy. It is at the core of therapy. Sometimes we unknowingly have our clients repeat things during sessions. Sometimes we do it purposefully. We want, once the child with a particular, like an articulation disorder, or an adult with apraxia of speech, when the person produces a particular word or a target utterance, you want the client to repeat it again, and you would have them repeat it again. And that is crucial. Repetition is crucial because you are, making sure the neural network is forming, that it is working efficiently. And repetition is really one of the key principles of neuroplasticity. And the reason is that repetition really supports the formation of new neural networks and pathways. So now that we know this, the big question really is, how do we structure repetition within our therapy tasks? How are we supposed to be having our clients repeat? Is it just verbatim repetition? Is there a specific way to have clients repeat? What's the recommendation for repetition, for using repetition within sessions? So that became the big question, and there have been many articles on that topic. And one article that really resonates with me on that particular question is this Rethinking Repetition in Therapy. And this article introduces two constructs. One is an isolated repetition, and another is conversational repetition. So although these terms might sound like they are new terms for some of you, I'm sure that we've all, even as student clinicians, that we have used them even unknowingly within sessions, and even in general during our natural conversations. So let's talk more about these two constructs. So isolated repetition is also called guided repetition, or a drill-based repetition. So I'm sure you're familiar with drill type of exercises that you would have your clients do. Where you're having the client, verbatim, reproduce words or sentences or phrases verbatim just after you. You would have them say it after you. So that's a drill type of repetition, or an isolated repetition. So the focus is really on immediate repetitions. It could be on verbal targets, it could be on motor targets. And these isolated repetitions can strengthen the pathways that are involved in motor learning. For example, if you are working with an adult who has apraxia of speech, let's say, and let's say you're having them apraxia of speech, or even any child, or when you're working with a child who has apraxia or articulation disorders or phonological disorders, you have the clients produce the words after you. You have a flashcards of different pictures, and you show it to them, and then they say it. If they're not accurately producing the words, you model, you give them cues, and then once they have the accurate production, you have them repeat after you, right? So that kind of a task does strengthen the motor learning, the ability to plan and program the motor movements of the oromotor musculature, or the articulators. The movement of that is being worked on when you are targeting, or when you're doing drill-based repetitions. And this type of learning, because it is isolated, because it is not really in a meaningful setup, the purpose is really, you show the picture and you have the client repeat, or you say the word, you have the client repeat. So that is an isolated repetition. Now that engages the non-declarative memory system. Now, if there are students who've not yet read about the different memory systems, I'll just very briefly tell you that there is this two broad classification of memory systems. One is declarative memory, and another is the non-declarative memory. So the non-declarative memory is also called procedural memory, and it really contains information about how to do things. So like how to ride a bike, how to swim, how to dance, those skills, those knowledge is stored in your non-declarative memory. And declarative memory, on the other hand, stores information about what. about what is the name of an object or the names of places, names of people, all of that, what information is stored in the declarative memories. It's the semantic information, let's say. So with the drill-based repetition, because it is isolated, it is engaging the non-declarative system, which actually is not very flexible, meaning when coding of information happens in the memory, when you are doing this particular drill-based exercise, the client will be able to, get better at that particular task that you're having them do. But it is a mastery of isolated skill. They cannot apply the same thing that they have learned to a different context because the system itself is less flexible. It cannot adapt and it cannot be used in another situation or with another participant or with another speaker. So there is poor generalization. And the reason is that non-declarative memory is really not supportive of complex and flexible communication. And communication really is so much complex. It could be one-on-one, it could be groups, it could be multiple people talking at the same time. There could be more than, like cultural adaptations, linguistic adaptations. This is just so complex. So non-declarative memory is not really, doesn't really have that flexibility. So we don't want the non-declarative memory to be engaged during the learning that we would want our clients to do in sessions. So contrast to isolated repetition is the conversational repetition or repeated engagement or meaningful repetition. Now, this is where you are having your clients repeat, again, different target words or utterances perhaps, but that would be in a meaningful situation. So there is a reason beyond just, well, can you say this after me or can you repeat it after me? Not just that. So there is a purpose behind it. Maybe it's within a conversation that you are having them repeat it. And it's not just purposeful repetition, it's also that it is multimodal. So you're not just having the clients repeat just words. You are also having the clients repeat gestures, even if the words are inaccurate, let's say. If the person has successful communication with you using gestures or using his AAC device, then that would require repetition because that was a successful communication episode. And then we do use repetition to support communicative success. And again, not just accurate productions. So you would want any kind of a successful event that communicatively was successful. There wasn't any conversational breakdown. The partner was able to follow what the person with aphasia said. That's a successful episode. And with conversational repetition, we want to repeat such episodes, even if the person's verbal utterances were not accurate. If this event itself was successful, we would want repetition there because, again, we are strengthening the network. Now, this type of a meaningful repetition engages the declarative memory because there are several pieces here. It's not just an isolated repetition. So when the declarative memory system gets engaged, the information that is being learned or the skill that is being learned is very adaptable. It's very promiscuous. It can be applied to different settings with different speakers, and it is very flexible. It can be used in novel situations as well. So the chances of generalization to other settings is much higher when learning happens with the help of the declarative memory system, as opposed to the non-declarative memory system. Now, this was the highlight of the article that I just showed you in the previous slide. And so with this idea in mind, I want to talk about how do we apply or how do we implement conversational repetition or repeated engagement within aphasia treatments. So here's the World Health Organization's ICF model. I'm very sure that all of you as students are familiar with it. I'm sure even Dr. Goswami's presentation talked about this model, while will mainly talk about this model from the aphasia interventions perspective. So for a person who has aphasia, when you're thinking about treatments, there is a broad category. One is the one that falls under impairment-based approaches, or also called medical-based treatments for aphasia, or traditional treatments. And another, which is psychosocial approaches. So the big difference really is that the traditional treatments really only focused on the body functions. And when it comes to body functions for aphasia, we are talking about, let's say, language comprehension, language expression. Those are the two big body functions that are affected or that are impaired, right? So these traditional treatments focus mainly on the impairments, and their focus is very less on the other components of the ICF. Whereas the psychosocial approaches for aphasia really do target all of the ICF components. That's the big difference. Now, of course, more recently, some of the impairment-based approaches have been adapted slightly to address some of the other ICF components, but most common and traditional approaches only focused on impairments, and that's the biggest difference. So I want to talk about psychosocial approaches a little more. The broad aim of this approach is to improve the quality of life of people with aphasia. That's the big aim, because we are not only looking at the impairment, we are looking at the person as an individual and his entire life, right? So how do we improve the quality of life? We do that by targeting natural interactions instead of clinician designed one-on-one, very structured programs. We are focusing on natural interactions. The focus is on personal consequences and social consequences. It could be where a person with aphasia, let's say because of aphasia, they're having problems in communicating with their spouses. Maybe they are going through a separation or a divorce. So how do you, as a speech language pathologist, how would you intervene so that the person with aphasia can communicate better with their spouse? Social consequences of aphasia, or participation in social events maybe is reduced, right? So they are perhaps not wanting to attend different events, not wanting to go out and be with their friends, or are not able to do any of those because of their communication disorders. So how can you make that a goal in your therapy sessions so that they can participate? Maybe you are teaching them how to talk on phone with their friend. That could be a goal as part of the psychosocial approach. Sense of self is how do you build, let's say, self-confidence, communication confidence, to be able to talk, to be able to present, a lecture, maybe, if, depending on the job or the educational background of your clients. Advocacy and social actions is another big focus of this approach. So here I want to give you this example of how I know this aphasia group who were really concerned about their local police officers not being able to talk on the phone with a person who has aphasia or other communication disorders. So there's a lot of times it happens in the US where people with aphasia are really living by themselves independently with their aphasia. So if there is an emergency, they have to call 911. And if the police officers are not able to understand them, then that becomes a huge cause for concern. So that was the concern that was brought to the knowledge of some researchers. So they collaborated and they really trained the police officers to be better able to communicate on the phone when there is an emergency and when they receive phone calls from people who have had aphasia. So that's one example of what psychosocial approach could really target. So what happens in a social, like what really happens in sessions when you're using a psychosocial approach? So in this approach, aphasia is viewed as not just a language impairment. You're looking at the individual as a whole. So you're looking at diminished participation in life and want to know what, you should be having goals that addresses that, and reduced fulfillment of social roles, and what can you do about it within your interventions. So the treatments that are based on psychosocial principles are really very, very client-centered. That means that the clinicians are no longer the persons of the authority. So they are not the authority figure. You as the clinician would give the authority to the client. They would be the ones that would be telling you what they want you to work on, rather than you telling them what they should, get better at. And most of the therapy activities that you would design would resemble very natural peer communication. So again, the power differential between a clinician and a patient would no longer exist. It would be like a peer-to-peer communication. And the therapy activities also should be very natural rather than artificial or like an experiment or like a clinician-directed tasks. So rather than that, you want the conversations or activities to be more natural, to be something that the client is really interested in doing as well. So again, I know I talked about this, but just to highlight why we need a social approach again, is that there are many limitations of the traditional impairment-based interventions. And one of the main ones are that the generalization to different contexts is very poor. The relevance to real life is very less. We are only focused on impairments. We are not doing anything else about their everyday life. The psychosocial well-being is not considered at all. And the other point is that the interventions that are implemented under impairment-based approach really is based on behavioralistic learning, which may not really apply for adults who have aphasia, and for adult learning might not be supportive of adult learning. So what is the learning mechanism or therapeutic mechanism in a psychosocial approach? So clinicians here are supposed to be skilled communication partners and flexible communication partners. So for example, let's say you have a client with aphasia, you want to implement a psychosocial based intervention. Let's say you select a conversation therapy method, right? Now you as the clinician are supposed to be skilled and are supposed to be flexible. What do I mean by that? So you are supposed to be creating natural situations. So it could be by introducing topics that are of interest for the client. You might really still have goals that are impairment focused. For example, you could still have, that the client needs to be able to name a particular set of words. Let's say the topic could be festivals or celebrations that happen quite commonly in India, quite frequently, I mean. And so if that's the topic of conversation, or the desserts that they want to eat during those festivals could be a good topic. And so if you're talking about that with your clients, your goal could really be, can the person really name the different sweets during a conversation? That could be an impairment-based goal. Can they really talk about it within conversations? Can they talk about the same with another individual? Can they participate more? All of that is a way that I would introduce the goals that could be impairment-based, but still I'm introducing them more naturally within a meaningful context. And I'm engaging the person in a meaningful interaction as opposed to a drill-based, I show the flashcard, have them repeat the word. Instead of that, this is a more natural social interaction. And most importantly, repeated engagement during this conversation about desserts and sweets for festivals could be things about, let's say the target word is laddu, okay? And if you want your clients to be able to say that over and over again to actually help form a neural network for that word, then you're repeatedly engaging the client. You just talk about laddus in different ways and give opportunities very strategically. You say, well, what do you really like? Or what color is it really? Or how do you really make laddus? And have those opportunities come up very naturally in conversation. So that's the skilled piece. And then you're flexible in terms of how much support you offer. You could really still cue them or provide reinforcements, encourage them to go on. And you can still accept responses that are not just verbal. You would still accept responses that are written or drawn or made via gestures. So you are repeatedly engaging the person in the same topic, but in a meaningful situation. So that's where you're skilled, and you would be a skilled and flexible partner, and you would be engaging them repeatedly in this activity in a meaningful way. And so that would lead to successful learning. Hopefully there is a neural network forming that would lead to internalization of that particular target. And so you could really create such activities either one-on-one in conversations. It could be a group discussion that would really stimulate a lot of complex conversations. And it could also be a part of games, which is another great activity that would stimulate and enhance plasticity. So now I want to talk about some of the psychosocial interventions that I have been working on. Collaborative referencing intervention is something that I started working on during my PhD times, and I'm still working on it even now. So this is an intervention that is based on psychosocial approach. Now, this intervention involves a client and a clinician sitting right across each other, and then they have two boards in front of them that are numbered 1 through 12, and there is a small barrier that separates the two so that they don't see each other's boards, but they can still see each other. They can still use gestures and communicate with each other, but they cannot see their boards. So what happens in this game is that I ask the clients to bring in pictures that they are really interested to talk about. It could be pictures from their own life. It could be about their vacations, their weddings, their jobs, whatever it is that they want to get better at. I have them bring those pictures into the sessions. And if they don't have pictures, I try to create some pictures based on the topics that they say that they're interested in. And then I use those pictures and I make a replica for the clinician. So they both have the same 12 pictures in each session. And the game really starts with the client arranging those 12 pictures on his board in any random fashion. And the clinician cannot really see how the client arranges those pictures. And the client's job is to describe to the clinician what each of those pictures is and where it goes. So it could be something like, okay, so it's my wedding picture on number 1, it's my daughter on number 2, or whatever. So that's the game. And then once they place all 12 pictures, it's the clinician's turn to do the same. So they take turns. There is a total of 6 trials in each session. And they do this, they play this game of matching the pictures to their locations. But that's just the game. That's not the therapeutic piece, right? So the therapeutic piece here is the amount of opportunities that the clinician creates for the client to produce those names or share those stories over and over again, 6 times or more sometimes in each session. So the goal is for the client and the clinician to come up with labels or references for those pictures. And what really happens that is therapeutic is that repeated engagement with each other in referencing, in coming up with names. And what is really cool about this is that the clients end up sharing so many stories from each of the pictures of their wedding, of their kids, of the vacation that they took. There are so many stories, there are so many jokes, but each of the stories really is an opportunity for the client to use the same name or to come up with another way to say it. So the brain is really being engaged in a very meaningful way over and over again in each session. So that is supposed to be triggering learning. It's supposed to be enhancing learning. So what really happens is across sessions, the clients really are able to complete those trials very quickly. They reduce the number of words they use in each trial. They simplify the labels as well. So I just want to show a transcript from my article from this, from AJSLP, where MB is Mr. Bear. This is the pseudonym of our client. And M is Martha, who is the clinician. And the target photograph that they are looking at is Mr. Bear's wedding picture. So this transcript is from CRI session 5. So treatment session 5, treatment session 10, and 15. So it is the same picture that they are referencing across sessions. I just wanted to put this up to show you the difference in how referencing changes across sessions. So as you can see in this first time that they're looking at this picture, Mr. Bear has a long name, has some pauses, has some hesitations here and there, and then they finally end up with wedding photo on number 7. In session 10, there is still some hesitations and filled pauses, and again, some back and forth, and finally he says wedding picture. And then session 15, however, is very short. He just straight away says number 4 is wedding, and that's it. So this indicates that the effort, the collaborative effort reduces. The time taken to reference one single picture also reduces. The number of words they used, number of gestures they used also reduces. So, and also the label itself, the reference itself has simplified across sessions. So this is one good example of learning that is happening during treatment while they are having a conversation. Now, since this happened, like learning within conversations happened. So now I was interested in, well, can we really see the effect of this learning of names within conversations? Can we see that on naming tests, like on a clinical naming test? So I wanted to do a confrontation naming test to see if those learning that occurred during conversations would actually be evident in a confrontation naming test. So I did this pre-efficacy study as part of my PhD dissertation. So I had 4 people with aphasia. They completed 15 CRI sessions, and they had 5 baseline treatment probe and maintenance sessions. And I had confrontation naming tasks in each of these phases. And as you can see, the confrontation naming scores definitely improved after the treatment was initiated. So there was a big difference from their performance during baseline to treatment. And the treatment effect size was also documented. So this was a good sort of inversion to our thinking about, acquisition to generalization to conversation. Now this one was doing the opposite. We tried to intervene within conversations level, and now we tried to see if that was, if the learning was evident in a clinical task. So that was the finding from this study. So now I want to also just highlight some of the other approaches that can be used to implement repeated engagement apart from CRI. So conversation therapy and group therapy for aphasia are 2 other interventions, and there are many more. I'm just focusing on these 3, mainly because I have worked on these 3. So conversation therapy could be individual or could be done in a group, but the goal of conversation-oriented interventions is that the therapy is directly focusing on changing behaviors within conversations. This is very different from the impairment-based treatments that really aim to work on skills at a linguistic level in isolation and then move on to natural conversation. So this is the reverse order for sure. So the conversation-oriented treatments are many, and they even take different forms. It could be conversational coaching. It could be one-on-one, conversation-based interventions between a clinician and a client. It could even be like Spark, which is another type of conversation treatment. So you can also implement conversation therapy within group treatments. Now, group treatments for aphasia initially started off as support groups. So this is not where speech language therapy was being provided. This was support groups for people who had had stroke. They met, their families met, and they kind of supported each other at different levels. And so that's how it started off. But gradually, different types of interventions became a part of those groups. And in 1999, I believe, Roberta Ellman, who has the Aphasia Center in California, she published this book on group therapy for aphasia. And she did a clinical trial for aphasia, clinical trial for group therapy for aphasia. And that kind of really opened up this huge area for aphasiologists to really work on, because the power of group therapy was just so immense, because it was a very complex environment, and you could really use it to do several different types of activities. It could be games, it could be conversations, could be role play type of activities, discussions, and the clients really connected with each other. So their participation in conversations improved, their confidence improved because they felt like they were connected with each other, they talked more. So it was just a very different intervention than what was studied before. So even right now in the US, we have lots of aphasia groups that are mainly being conducted as part of universities, because students lead some of these aphasia groups. So that has become very powerful, and conversation therapies are being implemented both as individual sessions and as group sessions as well. Now, this topic is really very vast, and I cannot possibly cover that also today. So I just wanted to pull this one slide up. So this one document comes from the article from Dr. Simmons-McKee in 2014, who highlighted different methods that can be employed when you're doing conversation-based treatments, either one-on-one or in group. And so as you can see, there are different types of supports that you can use. Multimodal communication is absolutely encouraged and supported. And also you're facilitating different types of activities. Like I said earlier, it could be talks that the clients themselves want to give. It could be role play type of activities. It could be sometimes the clients come up with different activities themselves, like leading yoga groups for people who have aphasia. And that also involves so much of communication for the person who is providing instructions. That's one example of what we did at the aphasia program in our university, is one of our clients did that. And you're also promoting conversational participation by having clients lead different topics, maybe when they are in groups. And throughout this, you can also use lectures, or also include aphasia awareness and education as part of the goal for your clients. For example, I invite some of my patients with aphasia to my aphasia classes. And so before they come over, they work on what they want to say, how they want to tell graduate students or undergraduate students about what aphasia really did to them, or what they really need from clinicians. So the clients themselves are working on it as part of their therapy. That's their goal. And they come into my class and then they talk about it to students. So that could be another way to engage the clients in different types of activities within group sessions. So I think that those were the three big psychosocial interventions that I really just touched upon today. Those are really huge topics. So with that, I think I want to just highlight some of the things that I would say would be the take-home message. One thing would be that as clinicians, I would definitely encourage you all to rethink some of the strategies that you have been typically using for your clients with aphasia. Question yourself, ask questions to your supervisors about how does making this goal really serve the purpose? Can the goals be different? Am I really collaborating with my clients in forming those goals? Am I being the one with the authority during sessions? So rethink those strategies for sure. And the other big thing is that I would encourage you all to be really skillful and plan ahead of time before your sessions and create opportunities for meaningful repetition. So that's one of the key things I would say is what type of repetition are you really implementing? Think about it. How can you make it more meaningful rather than drill-based? And finally, I would say providing home activities to clients is a very powerful thing. As a student, I did not think about it much. I thought it was just one extra thing that I had to do to prepare for clinic was to do some home activities. But it's really very powerful because you are engaging the clients to encourage them to use those tasks at home with their spouses or with their family members. So that's just one more piece of complexity that you're adding to those neural networks. So you're giving more chance and more probability for recovery, a higher probability for recovery. So those would be the three big take-home messages. So then the next question is, where do we go from here? What's the future? What does it look like? I think the most important thing is that we need to build more evidence on psychosocial approaches. We are still taking baby steps here. As far as collaborative referencing intervention goes, I am definitely planning to conduct a clinical trial for CRI. I have made some collaborations with different universities to be able to do that hopefully next year. But the other thing is that we need to study CRI within multilingual contexts and in different cultural contexts like India. So this is where I would definitely be open to and I would welcome collaborations from students and faculty members at JSS. I would love to take this up and study this in especially Kannada speaking population or even other contexts. Another area is the conversation-oriented treatments and group therapy. So in this area, we need to study the structure and impact of these treatments because it has been quite a while since lots of aphasia programs in the US have adopted these interventions, but there is still a lack of adequate evidence on how much is it impacting. So that's my next step, is to conduct some studies on university-based aphasia programs. But again, looking at the Indian context, I think we have limited research on this area also. So again, I'm very interested in this topic and I welcome collaborations from faculty and students. I think one way to go about doing this study in India would be to really just use the fantastic student-led programs that we have, even in JSS, for example. The graduate students and the undergraduate students lead several of these therapy sessions. And so I think it's very doable and practical to implement these conversation-oriented treatments and to study the impact of it. So that I would definitely be interested in that. So on that note, I would like to acknowledge all the participants with aphasia and their families for being a part of research and for helping us build evidence on this topic. I would also like to thank all of my undergraduate and graduate program mentors from JSS and AISH, who have definitely been responsible for all of my foundational knowledge in this discipline. And I also want to thank my doctoral program mentor, Dr. Julie Hengst at Illinois, and my current collaborators. Also acknowledging all of the student researchers in my lab at Western, and all of the student collaborators at the Discourse Analysis Lab in Illinois as well. Here are the references. Thank you so much for being so patient and for this opportunity again. I have listed my email again over here for people who are interested in collaborations and also for questions. Thank you so much.
Thank you very much, ma'am. It was indeed a very informative session. You have highlighted the therapeutic mechanisms behind the psychosocial approaches, and it was also a wonderful opportunity for us to learn about the collaborative referencing intervention technique. Thank you very much, ma'am.
Thank you.
We have a few questions posted, ma'am. If you permit, can we take them up, ma'am?
Absolutely.
Okay, the first question is, with respect to collaborative referencing intervention, what home activity would you plan for individuals who live alone?
Yeah, that's a good question. And that happens quite a bit, especially in the US with the type of social society structure that we have over here. There's lots of clients who live independently and by themselves. So one good thing is that there's, if not family, there is usually a friend or a neighbor, or there's usually one other person that the person can depend on. And so I would definitely encourage the clinicians to meet with that significant other, whoever that may be, and provide the training for that person as well. But in that rare case where there is literally not many people, and we've had that experience also, where the kids really live in different states and are not able to come over or meet with their parents. And so in those cases, I have adapted the intervention to being done electronically as well. So I would even have the clients talk on phone with their kids or with their other family members, and to do the same kind of activities. So like it could be the person trying to describe a particular event that had happened in the past, and the person with aphasia would have to actually guess maybe what the event was, or try to come up with those names of what places they went to or what vacations they took. So I do this very routinely, and I even have clients when they're driving in cars, for example. One of my clients actually did this with their spouses. They're both in the car. The spouse spots random things in the street and tries to describe them as they drive past those posts. And the client with aphasia would have to like think about what it could be. It could be like a stop sign. It could be a red signal or whatever. But they're again involving in that activity of guessing of what it could be. So there are different ways that you can really adapt this and use it for the advantage of your clients.
Thank you, ma'am. We have another question. What are your thoughts on art therapy for individuals with aphasia?
Yeah, another great question. I think there are different types of holistic interventions that are coming up, including yoga for aphasia, including aquatic therapy for aphasia, dance-based interventions. And art is definitely a part of all of the things that I just described. And the highlight here, when it comes to speech language pathologists, we are mainly concerned about their communication and how communication impacts their life, right? So regardless of what types of activities they're doing, be it painting or playing a piano or doing yoga, regardless of what they're doing, I would want my clients to have conversations during those activities. And that's the therapeutic piece. So how can whoever else is leading those sessions, how can they support or encourage conversations and interactions, and again induce plasticity by repeatedly engaging in those conversations over and over again, but in a meaningful way. So as long as there is some SLPs that could be present during these sessions to perhaps mold or shape the conversations in particular ways, then that would be fantastic. And in fact, especially in group therapy for aphasia, we do have art as being one of the activities that our clients work on together in a group, and they are having lots of conversations, sharing stories and jokes. And again, SLPs are present during those sessions. And we also have music therapy as part of our aphasia program here at our clinic. And music therapists bring in their musical instruments. People with aphasia who are interested in music use those instruments and learn different songs or tunes. And there are SLP students that are present in those sessions, trying to engage them in conversations as they try to figure out how to learn a new instrument, for example. So there are different ways, and another great opportunity for SLPs to collaborate with other professionals as well. So I like that question.
Thank you, ma'am. We have another question related to the technique discussed. Sir, can we take up the one last question?
Go ahead. I think you can ask.
Okay, sir.
So,
can
please ask Dr.
Yes, sir.
Suma.
Yes, sir. Can the CRT technique be used in multimodal ways?
Absolutely, yes. And that's how it has actually been set up. Sorry if I wasn't very clear on that. The way it is set up, the barrier is really a partial barrier. It's not a complete barrier. So you can really see the other person that is sitting in front of you. So you're using gestures, you're using facial expressions. Some of my clients even had their AAC device and used to, put up words that would pop up on their screen as they gave different letters, and they used to hold that up on the barrier to communicate with me. And I did the same too, especially I was working with a client who had Wernicke's aphasia, and he had a lot of jargon verbally, but his gestures were the ones that were really important for successful communication. So I had to use lots of gestures to communicate to the person about what I wanted to say. So multimodality is a big piece of CRI. Hope that answers the question.
Yes, ma'am. And that brings us to the end of the Q&A session as well.
Great.
Thank you, Dr. Suma. I mean, it was very impressive lecture, in fact. I'm happy that I could get your contact through Dr. Goswami. Thank you, Dr. Goswami. I mean, for giving me the number of, phone number of Dr. Suma. I mean, we are proud of you. I'm happy about the kind of work that you have been doing, and I wish you all the best. And thank you for accepting our invitation, and thank you for your presentation. I hope to be in contact with you, and we hope, of course, JSS has grown a lot in the last 10 years. So we would like to definitely have collaborative work with you. Thank you very much.
Thank you so much, sir. This was a great honor, and I'm so happy to be back. And I would love to come back in person whenever I can and see the new JSS as well. So thank you so much for this opportunity.
Ma'am, on behalf of JSS Institute of Speech and Hearing, I request you to kindly accept the letter of appreciation for being the resource person in today's webinar.
Thank you so much.
Thank you, ma'am. Participants may kindly note that the next session is scheduled on Monday, that is on the 19th July at 10 a.m. So kindly make it convenient to join us at the respective timings. This will be the last session of the webinar series. So we expect the same enthusiasm that was present on day 1 of the webinar. So kindly join us for the last session of the webinar on 19th. The timing is at 10. So kindly join us by 9:45. The feedback link for all the sessions of the webinar today has been posted in the chat box. I kindly request you all to leave a feedback regarding the same.
Thank you. We can collect the feedback. Thank you.
All right. Thank you so much.
Thank you for joining us.
Okay, bye.
Sanjana?
Yes, sir.
Yeah, so we have posted the
Yes, sir. Yes, sir.
feedback
Link.
10
Yes.
minutes back only. So probably we can end the session, end the meeting.
Yes, sir.
Yeah, thank you all. And please do join us on Monday morning 10 o'clock.